Good morning, good afternoon, good evening. My name is Walter Ricciardi. I'm professor of public health at the Catholic University in Rome and current president of World Federation of Public Health Association. And it is my pleasure and privilege to coordinate this first session of the opening session of the Global Public Health Week. As you can imagine and see, the world is in turmoil. To the additional challenges of inequalities, healthcare, access, and the traditional public health challenges, we are facing now the challenges of climate change and planetary health. In the past 2 years, we have struggled with the pandemic, and now also with war in Europe and other parts of the world. So the public health community want to, of course, not only advocate, but do something concrete to tackle these challenges. And that's why there are incredibly active participation of public health people around the world in this event that will be held during this week. But today, we want to start with a parterre de roi opening with the first introductory speech by the WHO Director General, Dr. Tedros Adhanom Ghebreyesus. Dr. Tedros has been the first WHO Director General elected from among multiple candidates by the World Health Assembly, and was the first person from the WHO African region to head the world's leading public health agency. Prior to his election as Director General of WHO, Dr. Tedros held many leadership positions in global health, including as chair of the Global Fund to fight AIDS, tuberculosis, and malaria, chair of the Rollback Malaria Partnership, and co-chair of the Partnership for Maternal, Newborn, and Child Health Board. And after taking office as WHO Director General in July 2017, Dr. Tedros initiated the most significant transformation in the organization's history, which has generated a wide range of achievements. So with this introduction, it's my pleasure to give the floor to Dr. Tedros, Director General of WHO.
Dear colleagues and friends, the COVID-19 pandemic is a painful demonstration of the consequences of underinvestment in public health. For too long, too many countries have invested heavily in advanced medical care, but neglected investments in public health. When the pandemic struck, many were overwhelmed and struggled with basic public health functions such as contact tracing. By contrast, many lower-income countries with fewer resources but more experience of epidemics have developed strong public health infrastructure. That muscle memory for outbreak preparedness and response has served them well. Let's learn the lessons of COVID-19. First, the time to invest in public health and to address the underlying social and economic determinants of health is before a crisis hits. Second, the bedrock of public health is strong primary health care, which has the trust of the communities it serves and acts as the eyes and ears of the health system. Third, the pandemic has demonstrated the incredible power of innovations in surveillance, genomics, diagnostics, vaccines, and therapeutics, but also that these innovations can serve to widen inequalities rather than narrow them. To build a safer world for a safer future, we need a commitment to public health, a commitment to primary health care, and a commitment to equity. I thank you.
Thanks very much, Dr. Tedros. And now it's my real pleasure and privilege to introduce the Right Honorable Helen Clark. Helen Clark is the former Prime Minister of New Zealand and former Administrator of the United Nations Development Programme, the UNDP. She came to the role of Prime Minister after an extensive parliamentary and ministerial career. And prior to being elected to the New Zealand Parliament in 1981, Helen Clark taught in the Political Studies Department of the University of Auckland, from which she earlier graduated. Helen Clark continues to be a strong voice for sustainable development, climate action, gender equality and women's leadership, peace and justice, and action on pressing global health issues. In July 2020, she was appointed by the Director General of the World Health Organization as a co-chair of the Independent Panel for Pandemic Preparedness and Response, called for by the World Health Assembly which reported in May 2021. She chairs the boards of the Extractive Industry Transparency Organization, the Partnership for Maternal, Newborn and Child Health, and other public good organizations and initiatives, and is a board member of others. So, Honorable Clark, I have the pleasure or privilege to giving you the floor, please.
Thank you so much, and greetings everyone from New Zealand to all of you wherever you are in the world at this time. And thanks for the opportunity to participate in this first Global Public Health Week hosted by the World Federation of Public Health Associations. Throughout the more than 2 years of the COVID-19 pandemic, public health has been at the forefront of national and global responses. Arguably, its role has never been more prominent and visible than it is today. Yet, and I may sound like an echo of Dr. Tedros in saying this, going into the pandemic, public health was in so many countries the poor relation in health systems and wasn't getting the sustained support that it needed. That had to change very fast as pandemic response plans had to be rewritten to cope with this novel coronavirus, as guidelines were developed for how transmission could be curbed, as surveillance systems were dusted off and put in place, as the skills of epidemiologists were drawn on to understand the distribution and patterns of the virus, and as preparations were made eventually for the rollout of vaccines across all age groups on a scale never seen before in the world, at least for those countries fortunate enough to access them. And I'll return to that point. I've spent a good deal of the past 2 years immersed in trying to understand the evolution of the pandemic and how the world could apply the lessons which should be learned from what has been a catastrophic experience, and one which continues to take a heavy toll on human life and health and have wide-ranging social and economic impacts. I was, with President Ellen Johnson Sirleaf of Liberia, a co-chair of the Independent Panel for Pandemic Preparedness and Response, initiated by the World Health Organization's Director General, Dr. Tedros, following a resolution calling for it from the World Health Assembly in May 2020. In May last year, our main report was released titled COVID-19, Make It the Last Pandemic. And we made 2 sets of recommendations. The first on measures needed to end the current pandemic, and the second on reforms to the global architecture around pandemic preparedness and response. On the first set of recommendations on ending the pandemic, we in effect made a rallying cry for Public Health 101, for the application of public health measures systematically and rigorously in every country relative to the state of the outbreak, with the aim of curbing transmission and bringing the pandemic phase of the disease to an end. I must say that what continues to astonish me is the extent to which proven public health responses have become so politicized in so many countries, with vocal minorities claiming that their freedoms are somehow being limited by the most basic of requirements, like needing vaccination in key occupations, having to show evidence of vaccination to access certain services, and even the need to be masked. This is the first truly global health crisis to be faced in the social media age, and it has proved to be very challenging to deal with it through the fog of fake news and conspiracy theories. Vaccination is clearly a critical part of the public health response, but its rollout has been problematic in several senses. First, we've seen a number of countries quickly abandon proven public health measures aimed at curbing transmission as their vaccine rollouts advanced, leaving, of course, room for the virus to progress through society. As the WHO has continually emphasized, a vaccine-only strategy won't work. Vaccination has to be accompanied by the other tools in the public health toolkit. And if it isn't, we leave the most vulnerable in our societies to pay the price, including the elderly, those with underlying health conditions, and those who, for a range of reasons, may be marginalised. Then we've seen the profound inequity in the rollout within countries and between them. At the global level, high-income countries ordered roughly twice as much vaccine as they needed, but they've been and continue to be tardy in sharing their surpluses. Our panel called for 1 billion doses to be redistributed by last September and another 1 billion by mid this year. Action's been slow, and it has been depressing to see vaccine supplies reaching countries when they're too close to expiry, making it all but impossible to use them. The WHO also set targets for the vaccine rollout, including for at least 40% of the population of every country to be vaccinated by the end of last December. More than 90 countries missed that target, including most countries in Africa, all but 7, as I recall. The target for 70% of all populations to be vaccinated by mid this year seems very unlikely to be met, and it's estimated that it won't be met across Africa before sometime in 2024. Of course, the global vaccination response needs to be fully funded, which is an ongoing challenge. As well, the knowledge and technology transfers required to broaden production around the world have been impeded by the failure at the World Trade Organization to negotiate speedily on the much-needed waiver of intellectual property rights. This seems, frankly, obscene in the face of a deadly pandemic. Our second set of recommendations proposed major changes to the global health architecture around pandemic preparedness and response. In short, we called for setting up a Global Health Threats Council, led at the head of state and government level, mandated by the UN General Assembly, which could bring leadership and accountability to pandemic preparedness and response. We recommended a standing financing mechanism for pandemic preparedness and response, which could allocate at least $10 billion a year on the basis of need and up to $100 million in surge funding in the event of a pandemic threat emerging. That early response is so critical. We recommended a pandemic framework convention negotiated under WHO's constitution, which should fill in gaps in the international legal framework and spell out clearly the roles and responsibilities of member states and international organizations. We strongly recommend developing a new pre-negotiated platform for the development and allocation of the global public goods required to fight a pandemic. This needs to move away from the market model with charitable funding, which has plagued Act A and COVAX. We need a new end-to-end platform which can ensure that a range of goods from PPE and oxygen to existing vaccines, diagnostics and treatments, and future ones, including new vaccines and treatments, can be equitably developed, manufactured and distributed. We did recommend more independence and authority for WHO through more sustained and predictable base funding and by empowering it to act more decisively in the face of emerging pandemic threats. We found that WHO was underpowered and underfinanced to do the job required and expected of it. Now, we've seen over the past almost a year since the report was presented, progress on a number of those issues to varying degrees. The decisions taken at this year's World Health Assembly next month will directly respond to some of our recommendations. And yes, the negotiations for a new global legal instrument are underway, but scheduled for completion in May 2024. Hardly a fast track when one considers the pandemic by then will have been 4 years ago from the beginning. What's imperative in the immediate future is to place equity at the centre of global pandemic preparedness and response. Everyone on Earth needs access to the diagnostics, the vaccines, and the therapeutics which will play vital roles in the response. With political will and global solidarity, that can be achieved. The question is, can that political will and solidarity be mobilised in the troubling times in which we live? The spread of COVID-19 has so clearly exposed the underlying fractures in our societies. And learning from this pandemic, surely we must see health equity as a core component of pandemic preparedness and response. Inequities in the social determinants of health to a great extent explain differences in COVID-19 outcomes within and between countries. For example, inequalities in people's ability to follow public health and social measures have often depended on whether they have access to social protection and safe housing, or whether they literally have to expose themselves to risk to put food on the table for themselves and their families. Countries now need more than ever to be investing in public health. The best practice gained from responding to this pandemic must be codified and continually reviewed to optimize responses to future pandemic threats. In that best practice, there must be an acceptance that there are not one-size-fits-all approaches globally or within countries. Communities have to be part of designing and delivering what will work for them. Otherwise, we will continue to leave so many behind. We are all, frankly, tired of COVID-19. We're fed up with the disruption it's caused to our lives and our societies. Unfortunately, COVID-19 is not tired of us. So throwing the whole public health toolkit at stopping transmission is vital, as is mustering the energy and the political will to be prepared for the next pandemic threat that emerges. We will have to work across sectors and engage every community to get this right. My thanks go to all in public health around our world who've worked tirelessly to respond to the extreme challenge posed by COVID-19 and put in place the wide range of measures needed to curb transmission. The job is not yet done, but it can be. The global public health workforce has an indispensable role to play in bringing this pandemic to an end and ensuring that our world is better prepared next time it's confronted with such a threat. Thank you, and back to you, Mr. Chair.
Honorable Clark, thank you very much for your inspiring presentation. I think that the global public health community fully aligns with the conclusions and the recommendation of the panel that you co-chair. And now we are perfectly aware of the difficulties that we are facing. And that's why we are starting a roundtable now together with the International Federation of Social Workers, because none of the challenges that you described can be won and fought alone by any kind of discipline or professional. So we have to work together. I know that you have to leave, but you can stay for a while, and I encourage the people from the audience to take advantage of the few minutes that the Honorable Clark can stay in case you want to ask some questions to Honorable Clark. So thank you very much, and thanks and congratulations for the great job you did and for the great job that you will be doing in the future for the health and welfare of the country, of the globe. Thanks very much. So it's my pleasure now to introduce the participants of the roundtable. As I said, we would like that this week and these sessions today represent a starting point of a much more integrated collaboration between the World Federation of Public Health Association and the International Federation of Social Workers. That's why we have two representatives from both organizations, and I will introduce themselves as I will give them the floor, starting from Professor Bettina Borisha. Professor Bettina Borisha is the Executive Director of the World Federation of Public Health Association. She is also a Professor of Global Health at the University of Geneva. a medical doctor and a histopathologist. She holds a Master of Public Health and is a fellow of the Royal College of Pathology. She directs the headquarters since its relocation to Geneva and represents the World Federation of Public Health Association in the widest sense. She is also the co-editor of the Journal of Public Health Policy Federation's pages. So Bettina, the floor is yours. Can you start from your point of view, but also from Honorable Clark? Fantastic introduction.
Yeah, thank you, Walter, but thank you also to Helen Clark for really introducing the topic. We have given the title of Health and Social Wellbeing in a Conflict Environment. What does it tell us and why did we do so? It's a fact that the world now has been faced with numerous challenges in a relatively short period of time. Dr. Tedros and Helen Clark talked mainly about the COVID pandemic. In addition, we face several other crises these days: geopolitical, health, climate, wars. But if we look back, we see that important changes in favor of health and social systems have frequently been happening during exactly such times of major crisis. Let me give you one example. The Second World War left the United Kingdom in a very critical situation. Wounded soldiers coming back from the war, cities and infrastructures completely destroyed, and no more money left in the public purse after years of war. And this was exactly the time when, following the advice of William Beveridge, the most important change in the social system of England was done. William Beveridge, a social economist who in 1942 published a report entitled Social Insurance and Allied Services that would provide the blueprint for social and health policy in post-war Britain. Beveridge had been drawn to the idea of working against social inequality while working for a charitable organization in East London. He saw that philanthropy was simply not sufficient in such circumstances, and that a coherent government plan would be the only sufficient action. His concept led to a social system, as well as to the creation of the National Health Service, the NHS. Why do I go back? What can we take? What can we learn? First, social and health systems are intimately linked and have to be co-created and co-promoted. Second, coherent government plans are needed. Philanthropy alone is not enough. And third, and this point brings us back to the title of the panel, it is exactly in times of crisis and conflict that we may be able to implement important changes in society. And the fourth point, Beveridge saw that social inequality, already mentioned by Helen and by Tedros, is the core. So he proposed a new social and health system. And here I would like to make a point. We are used to think and to talk in categories of high and low income countries. I feel this is simply misleading. Instead, we have to think and to work in categories of high and low income settings. What I want to say is that in every country, in every city of this world, you may find both high and low income settings. I can show you in Geneva, probably also in the US, places that are definitely low income setting, like in a low income country to be found. But Malabika, perhaps later on, will also tell us that in Bangladesh, you may find high-income settings. Why is this so? This is due mainly to the social inequality. And here, both public health community and social workers do see and face these inequalities regularly, every day during their work. Inequality and health, as we have heard, the pandemic has shown again, underlined this critical and crucial link that happens everywhere in front of our doors. The positive point I would like to make is that crises have opened up the minds of some to better understand this link and to understand its systemic implications. And we should use this so-called open window opportunity. Social well-being, physical well-being, and mental well-being are one. So let us use the times now to call for investment in social and health systems. Thank you, and back to Walter.
Thanks, Bettina. Thanks very much for your concrete proposal, which I think could be a very strong interest, not only for this discussion, but also for the mechanics of implementation in the future of both public health and social work interaction. It's my pleasure now to introduce Professor Malabika Sarkar. Professor Malabika Sarkar is a professor and associate dean of Bragg James P. Grant School of Public Health at the Bragg University in Bangladesh. She has more than 30 years of public health career, is a member of the International Immunization Policies Task Force of the World Federation of Public Health Association. She is a mixed method specialist and implementation researcher, so has published more than 100 articles and authored 3 book chapters, and is the International Advisory Board member of the Lancet Global Health, of the Medical Research Council in UK, and chair of the advisory board of the HRP Alliance for Research Capacity Strengthening. Malabika, the floor is yours.
Thank you very much, Walter, and thank you, Helen Clark, for your wonderful, starting talk. That's really inspiring. I just want to follow what Bettina started talking about, that we need to change our mind frame. We need to change this divide that low-income and high-income country and the policy formulate according to the low-income country and high-income country, because COVID has shown us nothing but how poor the many rich countries in terms of dealing COVID pandemic, whereas many small countries with actually little resource manage it very well. So we need to, if you look at the Bangladesh, and if we, that the data that the neonatal mortality is highest in the lowest economic group than the richest group, or is 3 times higher the women with no education than the women with education. Similarly, if somebody looks at the New York City data, that a Black woman has almost 3 times more likely to die from the pregnancy-related causes than white women. So because the way we allocate a resource, and as implementation researcher, the implementation strategy that we develop sometimes is very much this prescribed form. Okay, all low-income country, all middle-income country, or all high-income country. But that needs to be really changed in the policy, because the context does matter. The problem is that we think that the intervention which works very well, but that intervention, how we'll develop the delivery mechanism and how we kind of ensure that it will be reachable to our population, particularly disadvantaged population, we can't implement the similar strategy. We can't actually allocate same resource. So it's very important for us, even in the same context, not only high income, low income, or rural or urban, even similar settings, thinking about how innovative and how much resilient we make the health system so that it can deliver the service to particularly the most disadvantaged and the poorest population. Because the problem with the health system is now especially during the COVID, it's like a panic response, then neglect, do nothing. So we need to do the continuity because COVID has shown us not only the natural disaster, but the COVID, that anything can happen anytime and we need to prepare for them. And the most disadvantaged population actually suffer most. During COVID in Bangladesh, I know that there are several chartered planes from Dhaka, the capital, that all rich people flew to Canada and the USA or UK because they have the visa or they have the immigration status, whereas the poor people are trapped in their own livelihood and they suffer. So our policymakers need to be very mindful, even in their own country, that how to prioritize the disadvantaged population and think about the setting and the context and develop the implementation strategy and the service. Again, I'm just repeating it, but it's so important because it's always the poorest who suffer. Secondly, even if you think about the conflict, if you look at the refugee status, like I just came back from Germany, there are different kinds of refugee. So that the Ukraine refugees are much more better treated than the Syrian refugee who went there, or in the border, the African students and the Asian students were denied to enter. Then in Bangladesh, we have the Rohingya refugee, but they are not refugee. They are called FDMN, forcibly displaced Myanmar national. So the refugee status based on the immigration status and how their ethnicity, their color, their gender, they are discriminated. So this one size fits all, we have to change our mind and we have to shift that thinking and customize it and thinking more carefully about our citizen, our population, even our immigrant, our refugee, and think about that, how that can be implemented. And again, the policymaker, the policy is a piece of paper, but how the guideline will be developed, how the human resource will be trained, how the implementation strategy will be developed is very, very important. So we need to, again, to change I will just end saying that, change the mindset from the high income, middle income and low income country to actually the low income settings and high income settings. Thank you, Walter.
Thank you, Malabika. So it seems that Bettina's proposals meets your expectation and has your support, but let's hear what our colleagues from the International Federation of Social Workers think about it. And it's my pleasure to introduce Professor Anna Radulescu, who is the European President of the International Federation of Social Workers. She's also the CEO of the Center for Training and Evaluation in Social Work and Associate Professor at Bucharest University, the Faculty of Sociology and Social Work. A social worker by training, Professor Radulescu strives to strengthen the support and integration of socially excluded people and their resilience in the management of life risk. Professor Radulescu, the floor is yours.
It is an honor to be part of this event and to have the opportunity to present the need for a rethinking of health and well-being policies. This is urgently needed. The gaps between the health and social services fail to address the interconnectedness of poverty, marginalization, and high health risk. These issues exist long before COVID-19. In recent months, we have increasingly seen that poverty is associated with poor health. The mutual influence of the precarious living condition and state of health has been sufficiently proven by countless studies. Lower or insecure income is associated with more factors that are detrimental to health and limit opportunities for good health. Conversely, poor health has a negative impact on the financial situation as it limits opportunity for good and stable employment. During the last months, poverty, inequality, and social exclusion have increased. To echo Ms. Clark, more than ever, a large part of the population is threatened and affected by a massive deterioration in social and health support system. When effective social protection systems are in place that focus on both health and well-being, people who have lower incomes or less education are less at risk and increased health problems. Research showed that where comprehensive social network and access to social services and medical care exist, there are few gaps and deficits negatively affecting people's lives. The pandemic and devastating war in Ukraine, with the situation of refugees in many countries, make this situation painfully visible.
The combination of mental, physical, and health stress on the one hand, social and medical security and access to the labor market and decent housing subject the existing systems to enormous stress. To answer these challenges, health and social services need to expand their thinking beyond their current silos. There are two major issues we need to address together. To respond to current need, expanding eligibility for funding program or expanding social and health protections may be necessary to bring all these people into health and social protection systems. The other major consideration is for services designed to focus on promoting well-being and healthy lifestyles rather than focusing on reacting to crisis. We need a unified policy that recognizes the response to both social and health needs. The result will be a better work-health balance and improved living conditions. This is essential if we want to perform well in various responsibilities. Building multidisciplinary teams and joint social and medical strategies with local communities are the next steps. My work involves working with hospital emergency rooms where doctors and social workers cooperate for the benefit of their patients. The skills and knowledge and expertise of our professions working together with communities are, from my point of view, the solution. Across the world, we live in a time of climate crisis, inequality, human rights abuses, and under the effect of war. Therefore, a unified response from the health and social work profession is the right way to help people build public health and co-build their social well-being. So thank you very much, and back to you, Mr. Chair.
Thanks very much. And now we close the round of the world, going to America, to the fifth continent represented in this roundtable. And it's my pleasure to introduce Professor Marinilda Rivera-Diaz, who is a professor at the Social Determinants of Health doctoral program of the Graduate School of Public Health and affiliated researcher and coordinator of the International Health and Sanitary Sovereignty Working Group of the Latin America Council of Social Sciences. A commitment to the right to health of the people of Puerto Rico has been reflected in her academic and research work on mental health, the right to health and immigrant women living with HIV, neoliberal globalization, health inequity, and social determinants of health. She has actively collaborated with various professional, academic, and community organizations linked to the advocacy for human rights and the route to health. Professor Rivera-Diaz, the floor is yours.
Thank you very much. It's an honor for me to be part of this panel. Before I start, I would like to highlight that the current pandemic came to us maybe in a critical moment, no? Maybe the worst in the recent history, particularly for the South countries. This marked specific differences in how we respond to the pandemic and how the pandemic responses were articulated from the state and also from the society. As all we know, neoliberal policies implemented in the 80s by privatizing social rights, such as health, followed by a wave of austerity measures and a structural adjustment for the payment of the debt of our countries, lash out against a weakened system of health and social protection and has created a critical scenario that has placed us today in a very fragile position to face this pandemic. The first point I would like to introduce is the need to understand the connection between the society, the biology, and the nature. Since the beginning of the pandemic, the discussion about this origin focus on cultural habit of Chinese people and maybe the unhealthy management of food in the Wuhan market. It must be clear to us that what we have been facing is neither natural or something catastrophic that is out there threatening us. Rather than, we must recognize that the destruction of the earth, as we have been doing for the benefit of capitalism and the production and accumulation of capital, has created the basis for the emergence of epidemics like COVID-19 and other future epidemics if we do not radically change our way of living in this planet. Capitalist practices using the air as the main resource has been a mechanism of a capital extraction from other other countries in the southern countries. In our Latin American countries, this is manifested through extractivism, deforestation, generating consequences such as environmental contamination, forced migration, food insecurity, exposure to new diseases, and also extreme poverty. The second point I would like to discuss is to retrieve the gaze on the pandemic from collective and public health. This has to do with the urgent need to understand that people are the ones who suffer from the epidemics, and these require approaches from this dimension and not only from the individualistic biomedical model. The biomedical approach focuses its intervention from in the contextualized perspective of the relation between society and nature. This model leaves out the social dimension of health and therefore leave us without clear lenses to look at the causes of the causes that make some sectors more vulnerable to the pandemic. The government, based on this approach, responds to this pandemic generating tensions between sectors that are not in equal conditions to comply with the stay-at-home discourse. It is due to preventable and unfairly social and economic conditions created by local and international policies to which they have been subjected. Later on, I will discuss another third point that I consider very important, and also some proposals that we can discuss to eradicate or maybe to start building the way to eradicate inequality in health. Thank you very much.
Thanks a lot. We will start shortly the second round of this roundtable, but not before reminding all the participants that you can ask questions to our speaker, and that will be 15 minutes allocated after the second round of this roundtable. So please do not hesitate either to write your questions on the chat or eventually to send to our organizers. So we will start now the second round, and again to Professor Bettina Borisha, but I would like to raise some concrete issues. Some of you told that you are going to speak about concrete solutions, maybe taking some example in your part of the world. As Professor Sarkis said, we have to customize our response to that. My only provocation would be about some that has very rarely been addressed, which is structural racism, as part of our public health challenge. I have been really shocked by, again, the interview that was released today by a very famous soccer champions in France, Liliane Thuram, with the Foundation Thuram. They're saying, when Black people come from Ukraine to the Polish border, they are rejected simply because of the color of their skin. The other are refugees, and the people with Black skins are beasts. I was very shocked by this. Can you imagine how we, as a global public health community and social workers community, can tackle, or at least start to tackle, this structural racism that is affecting all our society? But again, I don't want to be too much provocative for your second talk, but please, Bettina, the floor is yours.
Thank you, Walter. But I think the point you raised, and I might directly react, is important. We have not yet accepted diversity as part of our world. This applies to all kinds of diversities. Myself being a woman, I know that women, for example, are treated in most countries like a symbolic minority. They don't have the same rights, they don't have the same access. So as a woman, you have most countries already experienced exclusion and, let's say, differential treatment. And it is, I think, one of our main tasks to come up with ways to implement the acceptance of diversity. May it be gender, may it be race, may it be all different kinds of diversity into our actions. It is written and it is said, but it's not yet implemented. Now let me come back to concrete proposals for health and social systems. And I think I put down what Anna said about health promotion. And I think one good thing was already said by doctors, medical doctors, who said, why do we treat people and put them back in the situation once we treated them that made them ill? So why do we get people out of situations for a while and put them back into the situation that makes their difficulties? Why do we save refugees from one country to put them in another difficult situation? And I think there we can really directly learn. I think, and here I come with concrete things. What I said in my first part was, William Beveridge already said we have to move away from purely charitable organizations, and the same thing was said by Helen Clark, but now for the global health architecture. And my proposal would also be not only move away from pure charitable to government action on the side of social inequality, but also on the side of diversity. It has to be part of government programs to act on diversity and on accepting diversity at all levels. I think we have to start in schools, and we have to start in medical schools, because I don't see a lot of medical schools who integrate questions of diversity and how to deal with it in their plans. And further on, I think it's a very political task. As Helen said, we were a little bit surprised how politicized a disease can be. That shows us that political work from our side, from the public health workers and the social workers, is deeply needed. And I give over to all my panelist colleagues, and back to you, Walter.
Thank you very much, Bettina. Malabika, please.
Thank you very much. I think, like, for structural racism, first thing is that we have to identify the structural racism, because the data is not available. It's like, individually who speaks up, and then, so there have to be an active process that to show that the structural racism exists, so that the data is very important information. Second, as Betty said, it needs to be with the education process, and not only the education in the curriculum, but how do they teach that? Because simple, the segregation, even like, some places I go and see that white students sit in one table and the Asian students another table and the Africans. So if we really want to build that, there have to be an off the curriculum initiative within the education system to kind of promote that how can we promote the racial harmony, or like, gender-based harmony. So that's very, very important. And then third is, I would also like to say that because they're like, is also have to be system that people feel comfortable and report that. Because most of the places, there's no place that a student or a patient can go and actually report and share that. So that going back to the data, we have to be like an active channel, so that like, that there have to be like a documentation, because the reason the structural racism exists is not only the legalization, but politicization is also the active practice, and people are not confronted that they are not confronted by the others that you are doing what you're doing is wrong. And finally, in the health system, I think our medical system is going through that. It's so much technology oriented. Tech is the medical, is the treatment, is the drugs, is the how do you treat. But the fundamental of, I would say that health service is the compassion. Without compassion, even compassion is, I think one philosopher, I forgot, is Schopenhauer or somebody say that compassion is the foundation of the morality. And we don't encourage and we don't kind of nurture the compassion component in our medical school. When I studied medicine, it's all about the treatment. So again, I think what Anna said, and that rethinking, that we have to rethink that how can, because it cannot be done only like, the policy of the policing or monitoring, because it have to come from your heart, that if we have to see the racism is bad, it is a sin. So like, if we have to promote it, like any kind of structural racism in terms of the religion, in terms of the culture, in terms of our norms and values, it's a sin, it's unacceptable, and it's against humanity. So these are the values, norms we need to include in our curriculum, and training for the doctors. I'm not going for the mainstream education because it have to be part of the mainstream education also, but as a like a health worker, that way the health worker curriculums, and during the process, it's always need to be nurtured and strengthened and have to be kind of showed that it's not acceptable. Because I don't think that only doing the policy, definitely there have to be policy, but structural racism also something which is invisible. You don't have to verbally spoken about that. You just have a look. That's enough for somebody that feeling intimidated or feeling neglected or like, humiliated. So I would just like, because we have to rethink and we have to kind of discover the curriculum and bring all those values to the health service delivery system and also education system. Thank you.
Thanks very much, Malabika. Anna, please.
Thank you very much. I'm also a practitioner. I'm a social worker working on the front line during pandemic. And now I'm, in fact, almost every day at the border working with my social workers, welcoming people coming from Ukraine to my country, Romania. So I would say that what we are doing now, what we did during pandemic days and months, and what we are doing now is really create a common strategy where we put social approach and medical approach together, because people coming from Ukraine these days, they need, of course, the first aid support, but they need then social support and medical support. So I will go with a concrete proposal to you, what we can do for this rethinking and for this common strategy. What about that International Federation of Social Workers, together with the World Federation of Public Health Association, establish a working group on redeveloping this policy that address this gap between health and social well-being, and come then with the experience of these two areas and put them together and find a common strategy. I think this is what we need, and we need from today, if possible, because we already have a lot of lesson learned during pandemic, and seems like, as Bettina also said, we need to answer to other situation coming, and let's use our experience in creating something that is ensuring resilience and sustainability for us, to be prepared for anything is coming in front of us. Thank you very much.
Thanks, Anna. Thanks also very much for your proposal, which I will be very happy to bring to our governing council. It seems a very concrete first step in the directions we are talking about. So let's walk the talk together. Marinilda, please.
Yeah, I'm totally agree with my colleagues and partner of this panel. And I would like to add maybe a concrete proposal, as Anna said. And maybe first, we need to raise in the importance of promoting an epistemic debate around the health, understood as a public good or a universal human rights, or health as an individual service or private merchandise for profit. Also, seems important to me that as health and social service professional, we have the responsibility to give direction to our work, maybe from a critical framework of human rights that urgently address inequality in our global community. And finally, it is urgent for us to think of ourselves as a new humanity in harmony with the nature, that place the care of life in the center and not in the market for profits. So that's what I wanted to say.
Thank you very much. We have 3 questions from the audience, which I encourage to follow on. The first one is from Juan Roman Mora Barrios. Are there any accountability and transparency models to be implemented in the management of further emergent and non-emergent public health and social well-being matter? Who would like to try to give a first response?
Yeah, I think that this question is really to the point on what we're discussing now, because it's the question also in the pandemic treaty discussions, what kind of accountability do we need? And that was missing in the international health regulations. And who has the power also to make countries or groups accountable, held them accountable? That is what is now at the stake. And I think we are about to create a new global health structure if we do it well. If we fail, this would be very, very difficult. But I think that the accountability mechanisms, as well as the transparency mechanism, are at the core of what is discussed right now. And it's exactly what was missing in the current pandemic until now. If I say transparency, I mean everything from distribution of drugs, from actions in different countries, back to a headquarter like the WHO headquarter, because this was missing. The international health regulations are there, but there was no accountability mechanism that could help also to get further. So I think very important part that is under discussion now. We do not yet have the instrument at the global level, but I think we should have one. So thank you very much for the question. Perhaps other people want to add something, or I give back to Walter and my colleague panelists.
Any other comment to this question? Anna, please.
Thank you very much. Just to continue what you said, Bettina, I think accountability must include communities that receive our services, and people receiving our services. They need to be part. They need to be part in this discussion as an active actor to health and social well-being. So we should not exclude this part in our discussions. Thank you, Bettina, please.
Walter, do I have the right to react on Anna directly?
Sure.
You know, we did a message at the beginning of the Ukraine war, and I said that exactly we, social and public health workers, listen to what people say. And when we hear what people say, we mean we need democratic organizations, because otherwise we cannot listen and react on people. So for me, one of the necessities for transparency and reacting also on communities is a kind of a democratic organization. Yeah, thank you. Thank you, Anna.
If there aren't any other comments on this question, I will go to the second question, which is, knowing that primary health care is in need of community engagement in order to achieve better health outcomes, how can systems promote equitable community participation if the community itself nowadays is stuck on individualism?
Let me answer to that.
Yes, Malabika.
So in a way, definitely, of course, community sometimes in the individualism, but I do think that community also expecting quality, good care from the primary health care. So there's expectation, whether it's the rich or poor or educated or non-educated. So if we kind of make the quality of the health care in the central point, and then try to mobilize the community to provide the quality of care, and what can be done if we, like, you know, the raising their voices, the community voices, and make accountable, again, going back to the accountable, the public health system. I think that there's one question about the quality of the data later on, like, you know, I've seen, I've read. So I think I don't think that community individualism will be limited that not to access the healthcare. or not to, because like a country like Bangladesh, where the out-of-pocket expenditure is 74% and 98% is in the private health sector, and people don't go to the public health sector because there's a poor quality of care. At the same time, they go to the, like, you know, the doctors are moonlighting, the daylight, the public health doctors are like, you know, not the public health, so the public sector doctors are even in private sector. So I think that we need to kind of make aware about the consumer right and the client's right in receiving the care. And another point, most often, I think most of the low-income countries, we pay tax. It doesn't matter very high, but we pay tax. I think there's a very lack of understanding about the right and privilege. So that, like, I think these are the things that the community, that is their money that the public sector is like, you know, spending and offering their service. So I do strongly believe that individualism will not hinder bringing community together, but more we need kind of mobilization, like a very precise message, and also the motivation and sense of ownership. If it can be done, I do believe that community will be engaged in improving primary health care overall.
Thanks, Malabika. Any other comment on this question? If not, I move to the question asked by Rory Truell. Bettina mentioned accepting diversity. What other key principles need to drive future policies that close the gaps between social well-being and health?
I just want to add here that I hope Rory Truell, CEO of International Federation of Social Workers, agrees with me that we do this group together, starting this working group together. And I hope in this frame of the working group, we will be able to close or to mind these gaps between social well-being, health. I don't know, Rory, if you can give us a message also, if the International Federation of Social Workers agrees with this proposal.
Thank you, Anna.
Also, I would like to add,
yes,
so Walter, yeah, as I mentioned before, I think that as a social worker, but also as a public health professionals, we need to work from a critical framework of human rights. No, human rights means and health. Human rights mean welfare and well-being. So I think that we need to start working on with that framework in mind.
Yeah.
Can I make, just to continue that, one thing I'm like a little bit, I don't have a concern, but I have kind of a little bit skeptical that when you talk of the framework, I think always we develop different kind of framework in my field I've seen, but that framework have to be operationalized so that people, those who are in the delivery point or those who are implementers or whether they have social workers, they understand what does it mean, because most often it's very theoretical, and we don't even in the training, we don't like kind of give very relevant example that in their life, how do they kind of understand that, how utilize that. So I would say that definitely framework is a good idea because it's kind of brings everybody together, but after that, it should not be stopped. We need to think about how can we make that a framework very operationalized and bringing relevant examples. So all our colleagues and peers who are in the front line, they understand and then they can execute that. Yes, over.
Yes, Bettina, please.
Yes, and I think that besides I like the working group between the two of us as groups, social workers and public health. But outside our groups, I think we also have to work on the mindset that still in some places, people think always in social help as charity. And I think we have to change it from charity to entitlement. It is your right. It is your right to health. It is your right to a correct social environment and social help. And I think if we go out to the public, this is one of the points I would really include, because too many places, even very close around me here, will perhaps think that basic health care is their right. But if it comes to a broader social right, they think it is charity and they say thank you and thank you, where it is their right. It's what they have in some countries paid for. It's not a thank you, it's your right. And I think this mindset to be changed is part of our work, should be part of our work. It is really moving the paradigm from charity to entitlement and right.
Thank you, Bettina. There are very positive comments coming from the audience. I just mentioned two of them, of course, Rory Truel, but also Luis Eugenio de Souza to the Anna's proposal. So I think it's a very good start. Another question from Juan Roman Morabarrios. There exist a lot of countries in socio-political crisis that are not only a public health matter because of protests and uprisings, but also due to the veracity of the health data collected from them, since local health systems are also corrupted and cover the governments. For example, Nicaragua officially reporting incredibly low COVID-19 cases, while independent health organizations kept high counts of the same. Is there any system in development to collect real health data? Very difficult question.
Okay, so I think there's many countries, depending on, again, if the government does not allow any independent or UN organization or international organization or independent body to collect data, then it's very politicized and difficult. But most of the countries, I know that, like, UNICEF or World Bank, or even there are like independent organizations who can collect real. I think that collecting the real data is not a problem. If you have the resource, you can collect. The problem is publishing it or kind of disseminating that information. So if somewhere the government is very restricted and they don't want, then I think it's very difficult. But there are a lot of tools are available now. It's not very even expensive to collect the data. Because people use device, the ODK and other tablets that real life data, it can be saved in the cloud, and easily somebody elsewhere can easily analyze the data. But the problem is if there's a really political agenda that not to publish, not to show, here comes the struggle. But in many cases that the countries, the international groups or development partners can, I wouldn't say that pressurize, but can have a conversation with the government, and then try to tell them that they have to allocate the resource and it's important for them. But there are a lot of ways now the health data can be collected. Yeah, over.
Bettina, do you want to add something?
Yeah, perhaps add something and link it back to what we have discussed. Indeed, there are mechanisms, but I think we need a stronger binding mechanism for publishing data, for transparency among countries, and that should be part of the discussions that are ongoing now. And there needs to be a compliance mechanism. And the second point that comes up with this question is the politicization of diseases and health. As Helen said in her introduction, the COVID pandemic was directly politicized on different levels by different political systems, and it still is the case. And we do know that political systems use diseases as to their own goals. As AIDS appeared, there was still the Cold War. Perhaps we come back to it, hope not. And in the USSR, it was clearly claimed that AIDS does not exist in the USSR because it is a capitalistic disease. So I usually tell this to my students to explain that diseases are used as political instruments. And we as public health workers, social workers, have to have very, very open ears to listen to even the first finest tune when a disease is instrumentalized, and it can happen. And I think in the example that our auditor was using, there may be also a political usage of having or not having data transparent. Thank you, and back to you.
If you,
Anna, please.
Oh, thank you very much. I think research and data must also include the stories of people on communities. And I think this perspective also enrich the information and the challenges people are having. So help us somehow to come with a better answer. So not only statistical data, but also to have the challenges, the story behind, and also solutions people, because most of them develop absolutely local solutions and resources. And I think in order to have broader view and an understanding, I think we also need the stories behind. Thank you very much.
Thanks, Anna. I just want to note a message coming from Manu Kau from New Zealand that underlines that the Indigenous Working Group will be discussing some of these issues and tools on Friday in a session on 9 a.m. CET. And this comes from Emma Rose on Tepatu and Adrian Tepatu. So thank you for this. Another question is, now that we are talking about public-private health sectors, what is your thought on public-private partnership in the healthcare systems? I've read some articles and none of them prove long-term benefits economically, nor in terms of quality of care. Does anybody wants to comment on this?
So there are a couple of examples. One of the best examples for public-private partnership, actually, tuberculosis, the DOT. So diet of the therapy, especially Bangladesh is a model because the government and the BRAC NGO, they jointly implementing the DOT last like 26, 27 years, because the BRAC has a community health worker who gives the treatment or the medicine to the patient at the village level, where the government is more training and provides. So that's a very good public-private partnership. And there are a lot other cases, like, in Pakistan, the general practitioner. But you are right, that public-private partnership is very much limited to this non-government organization or individual general practitioner. But, and they are, many cases is not the private for-profit or the government that actually doesn't function, because that's basically the private for profit. They're very much profit oriented. But there are, we know that social marketing company SMC has a very good partnership for promoting contraceptive. So there are examples, but I agree with you, because I think mostly the reason is that the profit making, or you also need to have a very structured program where that it can be monitored, that the quality of care, where, and sometimes government is also not interested. They want to showcase, because it's also, as we are discussing, not only negatively politicize disease, sometimes the positively also, to show them that, okay, is the government is working, not anybody else. But I agree with you that although last, I would say that 15 years, a lot of discussion about public-private partnership, but the way we expected that is to be blossom, it did not happen. I agree. Thank you.
Any other comment on this?
Just one sentence, if you allow me.
Yes, please.
I think public or private, they have to be accountable to people. And I think this is the most important point when we start to discuss this balance. They have to be accountable to the people.
That's a very good position. Thank you very much for this, Anna. There aren't any other comments, so I would go to a closure, asking all of you to give a very short statement about the Global Public Health Week and about your auspices and wishes for the Global Public Health Week, starting again in the same order from Bettina.
Thank you, Walter. Thank you to all my friends on the panel. I must admit that I am an optimist. Even in a situation like the one we are in now, where I understand that people look with sorrow at what's going on, I think we can take up our today's and tomorrow's situation as the challenge that will help us to implement what we like and what we were talking about. As I mentioned with my historical example, and this is not only one, think of the Great New Deal in the 20s after the financial crisis of the Black Friday. Again, a big crisis and an important change. For me, if we do it right now, we can really change things. And in some countries, political world, I do see it already. If it comes to the environment and energy sector, I see important changes happening quite quickly. If I see to the way how we live, there has been changes quite quickly. And I think if we all in the health field, the broad health and social field, put our long-term projects together now, we can make it and we can influence the changes in a direction we want. Thank you, and back to you.
Thanks, Bettina. Malabika.
I think it was discussed, and that the health cannot be alone. I think we have to realize that, to me, health is a cross-cutting issue. It cannot mean it's the center of our existence. So the way here, WFPHA and IFSW came together, like two organizations, more and more we need to bring more organization on the same platform. And those who are non-health, they also need to understand and prioritize that health is something that is very, very important. And if all of us don't work together, we will not achieve better health or health for all, which was 1978 Almata a slogan, which we have not achieved yet. It's 2021. We have MDG, SDG, but not health for all. So my expectation will be that more initiative like this, that bringing other partners, have an open discussion, and then try to formulate the solution and execute it. Thank you.
Thank you, Malabika. Anna, please.
I will say again about being a social worker in the front line. In many corners of the world, it is already happening that social workers are working with the health system, creating a common strategy for cases. And for 7 years now, social workers are working with the doctors in my daily work. So I see in practice how valuable is this common strategy. Therefore, I'm really, really confident that this work together will give us a possibility to come with a better answer at the policy level this time. Because at the practice level, we have to do it. But with help, as we can put this in a better context, I think we'll come back to the practice really in shaping our response to ensure for people a better answer to their needs. So thank you very much.
Thanks, Anna. Marinilda, please.
Well, for me, it's an honor to be here. Thank you so much for this great panel. And I would like to finish saying that maybe taking consideration that the crisis the world is facing are not only due to the coronavirus, no? It was there before. Also, the lethality of this virus didn't necessarily lie in it, but in the living conditions unfairly created by this economic system through exploitation and privatization of common goods. And we need to look the health with other lenses if we really want to eradicate inequality and also build better future for next generations. As Rory Truel, our executive director of International Federation of Social Work, mentioned it, and there is no public health without social well-being and vice versa. So thank you so much.
So thanks very much. We are coming to the closure of this very, very interesting panel and very important opening session. Helen Clark said the work has just started. There is a lot of work to be done. And I'm sure that we will keep willing and optimistic about the work to be done. And by the way, to be done together. And certainly there is a lot of work that is going to be done during this week. I encourage you to have more information on our World Federation of Public Health Association. We have set a specific page on the Global Public Health Week, where you can look at all the events listed, which are growing and growing in all over the world. And you can, of course, follow them or also live, but also they will be kept on our website for the information and the participation of all the public health and the social workers community worldwide. I want to thank very much all the speakers of this fantastic panel. I want to thank all the organizations that made this possible, the staff in Geneva, the staff virtually connected of the World Federation, our communication office. I think that we did a good job, but we just started. So thank you very much and best wishes to you all. Thank you.
Thank you, Walter. Thank you, everyone. Bye-bye.
Bye, everybody.
Bye.